So communicating with patients is going to start with an introduction. If they're awake, if they don't have altered mental status, you want to walk in and introduce yourself. I'm Susie. I'm a paramedic with EMS and whatever you're working with. And, what's your name? Use their name often. Don't belittle them by calling him honey or sweetie or anything like that. If he tells you his name is Mr. Brown, you call him Mr. Brown. If he, wants you to call him Michael, call him Michael. Use their name very often. Ask them what's wrong. I'm concerned. I'm here for you today. Ask them what's wrong. Maintain that eye contact. That's probably one of the essential things that you can do. Use language that the patient understands. If there is a language problem, try to find an interpreter. Get at their level. I love this picture. The EMT's there at eye level with them. Shows concern. Speaking slow, clear, and distinctly so that everybody understands. Always tell the truth. Is this going to hurt? Yeah, you know what? It might hurt a little bit, but it's going to be very quick, and then we're done with it. Don't lie to them. Allow time for the patient to respond. Ask one question, allow time for them to respond, and that's it. If you have more people, so especially a parent and a young child, sometimes you ask the 5-year-old what happened, and the parent keeps answering. So you can say, well, first I'm going to talk to mom and ask her what happened, then I'm going to talk to you. And that's a neat way of setting the stage for whose turn it is to talk. Be aware of your body language. Sometimes it shows that this isn't where you want to be right now. And keep your confidence. Always stay calm. This is their emergency. It's not yours. Respect cultural norms of the patient. Sometimes, especially male-female partners, the patient or the family feels more comfortable, more confident with the male responder. Sometimes you have to set the rules and say, well, this is my partner, and I'm the certified person or whatever. Otherwise, respect their norms, but don't change anything as far as what you need to do to deliver care. We talked about open-ended questions in patient assessment, and those are always good. If somebody tends to be going way off and your scene time is getting long, then you can kind of look at well, I had a heart attack. Well, what year was that? And then that's a very quick, question answer kind of thing. Best thing is treat all patients and as well as their family as if they're members of your family. With special needs patients, so if they're hearing impaired, like speech impaired, like I am, hearing impaired, sometimes they can hear some. So facing them when you speak is better, and it's not so much how loud you talk, but speaking slowly and distinctly. And surprisingly enough, people that have high decibel hearing loss, they can hear the lower tones but not the high tones. So women's voices are very hard for them to hear, but men's voices are very easy to hear. But do what you can, look towards them, speak slow. If need be, if you're not able to communicate that way, then bring out something that you can both write on. And that's easy to do. Write down your questions, they write down their answers. If somebody is visually impaired, again, they may have some sight, but be sure and tell them all the time what's going on. Don't just grab them and start pushing them back. They think you could be pushing them to the floor and you're trying to help them sit down on the stretcher. So think about that. If anyone has a service dog, the service dog stays with the patient, rides in the ambulance with them. It's just like you wouldn't tell them, well, you can't bring your cane to the hospital, you can't bring your hearing aid to the hospital. Of course they can. The service dog stays with them. For patients that do not speak whatever language is it that you speak and you don't speak their language, try to find an interpreter. Do the best you can with what you have. There's so many places now that you can call and if somebody came from China and they spoke Mandarin, you could find an interpreter for them that, via phone. In remote areas, one of the easiest things is if you have internet is to use maybe a Google app or a translator. You type in a question, you hit translate into their language, they read it, they type in the answer, and then hit translate back to you. So those are very easy to use. Don't assume all older patients have physical or mental impairments. Don't assume they can't hear you. So do your assessment and then see if they have any deficiencies. The biggest thing is to give them a little bit more time to respond to your questions. As far as pediatric patients, you're a stranger and you could possibly hurt them. They're thinking about shots, so be sure to keep the parent with the child as much as possible. If the child is being held by the parent, then a lot of times they tend to do better anyway. They don't scream and cry, and they do well. Getting down at eye level with them and getting at a personal level. Tell them your first name, explain to them all the time what you're doing. Sometimes you can distract them a little bit. Maybe they have a favorite toy, but assess them very slowly. And, just to inform them ahead of time. Nothing I'm going to do, this isn't going to hurt. I'm just going to listen to your chest, or I'm just going to, take your temperature or whatever. And the same with adults is be honest with them. If somebody is developmentally disabled, and this can be a long spectrum of, a wide spectrum of needs with different patients, but the biggest thing, again, is to take your time, talk to the family about their typical level of communication. Use short sentences, simple words. Maybe they're not responding to you, but they understand that. You may have to repeat yourself a couple of times. So if they do, though, get disruptive, let them know that that's not okay and that you have to protect yourself. So you always want to keep an exit behind you so that you can take that exit if need be. And don't take your eyes off the patient or turn your back on them, because sometimes, if somebody's disruptive at all, they may have a weapon, they may have an ashtray they can throw at you. But you want to be able to make that exit and then call for law enforcement there to help you. So as soon as you see that your safety is assured, then you can carry out your assessment and your care of that patient. If somebody's disruptive and doesn't want to go to the hospital, you can't take them against their wishes. So you would have to have either court order or say that this patient is at risk to themselves or others, and contact online medical direction. But if you're going to take them, you're going to need more than just you in the back of that ambulance to keep them restrained. And we only use restraints enough to not injure them, but just enough to keep them from hurting you. As far as medical terminology, there's a wide variety of terms that you can learn. And some that you should know are anatomic parts of the body, some specific illnesses, like if somebody said he had a cerebrovascular accident, you would know what that was, as a stroke. Being able to designate injuries and communicate those, and then treatments that we use. So if you're unsure of the meaning, the best thing is not to use the medical terms, just to use common lay people. Put on an oxygen mask on him. And if you do find that terminology is new to you, make sure that you look it up and add it to your vocabulary. And those will include not only the root words, but prefixes and suffixes. For instance, if somebody has tachycardia, well, we know cardia sounds like heart, and tachy actually means rapid, so they have a fast heartbeat. If somebody has hypoglycemia, well, glycemia means sugar, and hypo means low or deficient, so they're low in blood sugar. We get into documentation. It's a process for verifying what you've done. And we like computer-based records. The reason for that is sometimes our handwriting gets sloppy and it changes over the years, and you may not be able to read your own run report, much less somebody else reading that. The other thing about computer-based records is that they're stored electronically. They don't take up a whole lot of space, and a lot of them have drop-down boxes, so it makes sure that you're done with the report when everything is complete. If there's any omissions, it'll make you go back and fix that. So it's going to talk about age and gender of the patient, history of the incident, how you found them, and a description of that illness or injury, as well as chief complaint, level of responsiveness, your vital signs, that baseline vital sign as well as the subsequent ones, anything you found on the physical exam, parts of the sample history, and the treatment that you gave that patient. Big thing that it should include is change in the patient's condition. Upon your arrival, did they get better or worse? Or did they stay the same? What agency or personnel took over that treatment for you? Who was your handoff communication? You also have to document times, and all the times need to come from one source, or synchronized sources. Because if you don't have that, sometimes if your response is really close to your station, you can arrive on scene before you were dispatched if those times weren't synchronized. But those are the minimum times that you would need to see on there. And most people will tell you it took forever for y'all to get here. Well, we received the call at 10:11, and we arrived at the station at 10:13. We arrived at your house at 10:15. That's 4 minutes. That's a really good, response time. If your documentation has any reportable conditions like a dog bite or attempted suicide, maybe it's an infectious disease exposure, anything unusual about the case, then you may have to do an addendum to that form and have it go to your director or your supervisor so it can be followed up with. Try to do your run reports as soon as possible. A lot of hospitals are waiting for that documentation. Again, you're going to see things that nobody else in the care of that patient is going to see. And that's the field impression. That's what you saw at the scene. So the sooner you get your reports to them, the sooner they can create that continuum of care for that patient. So communication is a sender and a receiver, and it's important in all phases of that EMS call. In addition to the radio and oral reports, you have to have good interpersonal communication skills. You have to like people. You have to care for them. And that's a lot of reason why people take classes like this. Not only verbal, but your body language and your attitude kind of conveys messages to the patient, so make sure both of those are consistent with why you're there. Sometimes patients have special needs, children, geriatric, hearing impaired, visually impaired, non-English speaking, and so you're going to have to adapt and adjust your communications approach with these. Along with your radio report and your oral report, you're going to do a written handoff report that can be given to other EMS professionals, or if you transport, to the receiving hospital. So when we do the review for this, we think about communicating with a sick or injured person. It is important to use terms such as dear or buddy when addressing the patient. That kind of belittles them, and they'll receive it that way too. They may let you do that, but they'll receive it that way. Use only medical terminology, again, not if the other people don't understand that. Ask the patient as little as possible. No, we want to listen to them. We want to know as much as possible. The best answer here is maintain eye contact with the patient when you can. Correct answer D. Which of the following would be considered good communication? You talk louder so you can be overheard over the television. Turn the television off, then you don't have to talk louder. You initiate care without telling the patient what you're going to do. No, tell them all the time. Don't just grab them and grab their arm and put a blood pressure cuff on them. Let them know. You assess the patient while thinking about your last call. They'll see that distraction in that, so remember to focus on what's in front of you. Minimize your distractions during your conversation with the patient. Absolutely. Let that person know that what they have to say to you is most important. When caring for a pediatric patient, you should consider separating the child from the parents to avoid upsetting them. That's not a good idea. Speaking in an authoritative tone, you want to be friendly with kids. Allowing the parent to hold the child if the situation permits it. I like that one. Let's see if there's any more. Performing painful procedures without giving the child any warning. No, you need to tell them this might hurt a little. So the best answer there, allow the parent to hold the child if that situation permits it. So hope you got a lot of information from documentation and communication, and see why it fits so nicely in with